And he's like, you probably won't be able to get pregnant. I had to live with that. This is not a gynecological disease. It's a whole body disease that needs a whole body approach and needs specialists that treat it that way. Stop gaslighting us.
It's very under-researched. It's very underdiagnosed.
Yeah.
What do you think needs to change?
Here's one thing I need to say.
Well, Michele, welcome to IVF Companion.
Thanks. Thanks for having me. Super stoked.
And so you've clearly got a passion for what you do, for pelvic health, for endometriosis awareness. Mm-hmm. And so that begs the question, like, what made you dedicate your career to pelvic health?
Yeah. I mean, it didn't start out that way. I was, doing regular orthopedic kind of PT. And then I think after I had my daughter via C-section, I started having some problems that weren't there before. And I think just the more I learned about endometriosis, and then my daughter having endometriosis later on, just kind of really made me super passionate about breaking the chain, breaking the legacy of having to deal with pain and all the things that go along with endo and pelvic pain and all that kind of thing. So I'm super all about empowering women, especially to take care of themselves and to learn more about their bodies and learn about the roots of what's going on. So yeah, dispelling myths and all that.
For people watching who are, a lot of us are going through IVF, mm-hmm. trying to conceive, maybe have already had a failure, and endometriosis comes up in discussion forums when people are talking about IVF. It's kind of this nebulous topic for a lot of people.
Yeah.
Without the final answer, without the why, without the, how do I get there? And so it gets dismissed, the idea of it. Or, someone just doesn't know where to start.
Yeah. So technically, they say that endometriosis accounts for 50% of unexplained infertility. So that's one thing to consider. I actually think it could be more, just like I think there's more people that have endometriosis than 1 in 10, is what they say, because it goes undiagnosed for so long. In my experience, it's more like 1 in 4, 1 in 3. As far as how do you know if you have endometriosis, the technical way to find out is the gold standard of having a laparoscopic surgery. And that means with someone who's really a bona fide excision specialist who can identify the lesions, not just a regular gynecologist. But there are ways now to predict whether or not you could possibly have endometriosis. There's a test called MyReceptiva, which tests for certain markers that has been shown to be 80 to 90% high rate of possibility. There's also specific MRIs and ultrasounds. The ultrasounds usually are done by those endometriosis excision specialists because they know certain ways to manipulate the organs so that they can tell whether things are glued together. So it's not just going to a Health Images to get your ultrasound, right? There's also MRIs. There's a specific endometriosis protocol MRI that can detect. So these things can rule in endo, but they can't rule it out. So for instance, if you get an MRI and you go to have the endometriosis protocol and you have a negative, they don't find anything, doesn't mean you don't have it. So that's something to consider. I mean, the best way to rule it in is by having surgery, by having laparoscopic surgery. However, here's something to consider. There are people, such as myself, pelvic PTs, that are very schooled in what it presents as in the body. So myself and my therapists are trained to find areas where typically endometriosis shows up. And so we can feel in the body where things are glued together, basically. And there's a specific way that it shows up. For instance, the sigmoid colon along the left side wall, gluing together the uterus and the rectum, things like that. We can really feel those areas. That coupled with a thorough history of did your mother have endometriosis, or your sister, Or did your mother have a hysterectomy that we don't know why? Because a lot of times I'll find out after probing more and more, we get to spend a lot of time with our patients. So we get to know what they're going through. And so, we ask them like, tell me about your mother. Tell me about do you have a sister? Tell me about their history. Because a lot of times people don't have the typical symptoms of like painful periods, which endometriosis is so complex. It's not just a reproductive disease. It's a whole body disease. So people might have IBS. They might have constipation, chronic constipation for the whole life, unexplained abdominal pain that they've had, like they've been to GI specialists, they've been to like all the specialists and nobody's found what's going on, things like that. People that have been struggling with infertility for a long time, or like a lot of miscarriages. So those are like signs that people could have endometriosis. Does that make sense? So there's like a whole lot more. Headaches, migraine, like pain down the leg with your period, painful intercourse. There's all kinds of things, like difficulty with tampon insertion, like any of those things could be a sign that you have endo. So we piece it all together. And then, we can tell our patients, well, I think you might need to get this checked out. And then we send them to, like, there's a local excision specialist that we send them to. And he's like, well, if Michele thinks you have it, you probably do. So we have a really high rate of being able to predict whether someone has endometriosis.
And how do we know if we're finding a good surgeon for endometriosis excision?
Yeah, that's a tough one. There are some sites that have lists, like the I Care Better people. There is a Facebook group called Nancy's Nook. I don't know if you're familiar with that. That was featured in the movie Below the Belt, it's a Facebook group that's for educational purposes. And a lot of people will go to Nancy's Nook thinking that it's a support group, but it's not. It's really more for education. And Nancy is a woman who's been in the industry. She was the nurse to one of the grandfathers of excision surgery, David Redwine, who passed away recently. She was his nurse. And so she formed this group to like educate people about endometriosis. And so they have a list of surgeons on their Facebook group. And I have the list as well. I can send it to people. The list is determined by successful patients, like histories of working with those surgeons. And then I believe Nancy reaches out to them to find out that they for sure do excision surgery and such. So it's kind of a vetting, but not like a super professional vetting. It's more of a like patient-centered vetting. And the I Care Better people have a list as well. There's also some other platforms circulating now that have lists of surgeons. I think it's important to ask around and like find out from specialists. The problem is that a lot of regular gynecologists or people that are just doing all kinds of different gynecological type surgeries are saying that they do excision, and maybe they are doing some excision, but they're not at the level of the people that do it all the time.
Yeah, there's something to say about specializing.
Absolutely. Course. Yeah. So it's super important, even if someone like gave a talk about endometriosis or just really, really important to look deeper into who you're talking with and learning how to vet the surgeons, asking how many surgeries they do. And I think people are afraid to ask, but I think it's really important to advocate for yourself, to ask the right questions.
Yeah.
How many surgeries do you do a year? What percentage of your surgeries are excision surgeries? The people that are doing all excision surgery are the ones that you really, like the ones that primarily do that are the ones that you want to go to. Because otherwise, some of the surgeons are just looking at the ones that are visible, like the lesions that are visible, and they're not able to see the other lesions that are almost indetectable to the train. I look at the pictures from the surgeon and I'm like, that's endo? What? I don't see anything. There's like, he has circled it. And I'm like, I don't see anything. So because I haven't been trained to see those lesions, he has. So there's a difference for sure.
And I think that's important in women's health overall. And from what I know about navigating through IVF, is that I have to get over myself about thinking, well, that nurse practitioner, that doctor, they were so nice and I don't want to rock the boat. I don't want to ask too many questions. Clearly they know what they're talking about. They're speaking with such confidence about this procedure that I should do, this medication I should take, and this surgery that they know how to do. And you don't want to doubt people. You're tired and you don't know where the answers are. But I think when there are people and resources that can help coach you about what to ask. So what you're doing right here, how to find your way, how to choose your own adventure to get to the best surgeon that you can, that specializes and not worrying about hurting feelings along the way, because you're trying to create life. You're trying to do something really important. And there's no point in choosing to be swept along when there still needs to have so much more research done.
Yeah, you're entitled to know.
Yeah.
First and foremost. And so if someone's brushing you off and not giving you the answers, then you got to find another doctor because you really need to know. The other thing is that it's really important that you don't go to someone who does ablation.
Okay.
Because ablation burns the endo at the surface and leaves it underneath. And it can cause so much more damage than not having it done at all, like not having any surgery at all. It basically kills the tissue. And so, that's another important distinction, is asking in what cases will you do ablation and why, and then really sitting with that and maybe getting a second opinion. I think second opinions are important. Yeah.
I mean, first of all, I'm really surprised to hear 1 out of 4. I mean, 1 out of 10 is kind of the phrase that I hear more.
Yeah.
But with all of those symptoms or comorbidities that you mentioned, I'm really feeling that. After my experience of finding out I had endo, going to a surgeon, I kind of want to yell from the rooftops, like, more of you have endo than you think.
Totally.
But I was wondering, for those that can't get the surgery because they're just maybe not ready to jump into that, is pelvic PT, which you do, is that a way to, number one, get relief or maybe possibly prepare for an embryo transfer?
Absolutely. Yes and yes.
Okay.
And I would couch that as not just any pelvic PT, someone that really has the skill and knowledge about endometriosis, about scar tissue, and people that actually manipulate organs and adhesions and are doing more than just pelvic floor therapy, if that makes sense.
Yeah.
So when we treat our patients, we look at them from head to toe. We also incorporate nervous system techniques, cranial work, because the pituitary gland, all that stuff lives in the brain. And so endometriosis they now think is a neuroimmune disease. So we have to address the nervous system. And a lot of the nervous system lives in the gut. And so we're doing a lot of work with our hands on the viscera, the organs of the gut, the pelvic organs, the ovaries, all of that, as well as incorporating brain and nervous system work as well. And, not to forget the rib cage and diaphragm and all that stuff. But it's a whole body disease requiring a whole body approach.
And when you said glued together a couple times.
Yeah.
What are you talking about there? That sounds really dramatic. But
it's true. I mean, we joke around with our patients. We're like, oh, you have a bluterus. This is a bladder glued to the uterus, basically. So the way endometriosis implants into the body, the lesions are outside of the uterus, right? So that's another misnomer that people think. There's a lot of pictures of uterus with endometriosis, and it's not a uterine disease. That's adenomyosis. Endometriosis, by definition, is outside of the uterus, and so the implants can grow on the ovaries, the uterus, inside, like pouches in between organs, behind the uterus, in front of the rectum, and they can glue organs together. And that causes a lot of pressure, and it kind of makes things asymmetrical. So it kind of pulls on one side or another and can then cause this whole cascade of muscular contractions and guarding. And so it's a very complex situation. And so joking about the bluterus is the bladder and uterus. So we'll go up internally into you working on someone and will feel between the uterus and the bladder and be able to very slowly, methodically stretch those adhesions out. Sometimes we don't break them, but we just kind of change the structure of them so that that creates more space for the organs to do their job. So, like people can have their sigmoid colon glued to the left side wall, or, the bladder, or the uterus and the rectum can be glued together. So there's lots of different angles that we work to try to help our patients have more relief from period pain and to help improve their fertility. So yes, it could be very helpful to do this kind of work in lieu of IVF or in lieu of surgery. But, there are some people that really do need the surgery to, everybody's different. So it's really hard to be able to know.
Yeah. And even after the surgery, maybe?
Yeah, absolutely. After the surgery.
Which brings up for me, I've had one surgery, one excision surgery for endo. And maybe it's a naive understanding, but I'm thinking that I'm good now. Like it's all wrapped up. I'm going to be skipping off into pregnancy land now with no more symptoms. Yeah. But I have met people that have had more than one surgery. Yeah. Why might that happen? Or is that just like we live with endometriosis, it grows back? I don't know if grows back is the right phrase, but I hear it a lot. So I'm just wondering if you could speak to that.
It is a proliferative disease that's been likened to cancer. So if you think about, if you have cancer removed, it could grow back, right? However, every year we go to the endometriosis summit and we hear from the top surgeons, and a lot of them say that a good surgery, like a well-done excision surgery by someone who's really skilled at that, there's different levels of skill, can be a game changer. And surgery is not the end all be all. Of course, things can grow back, but they say that it's more of not a reoccurrence, but maybe they just didn't get all of the endo, and so it's still left behind. Like I know I've had some patients that come to me and they've had surgery and the surgeon left it on their diaphragm. And so that,
whoops,
because they're not, the surgeon, admitted that they weren't skilled enough to remove it from the diaphragm, or they didn't have a surgeon on hand, or they didn't do the workup before to know that there's a possibility that they could have it on their diaphragm. So they left it there. And so, that's left to grow. So is it a recurrence, or is it just that they didn't remove the endo? Does that make sense?
Yeah.
So you want just like with any cancer surgery, you want clean borders and, all that stuff. So yeah, it's sticky. I mean, there are some people that have had really excellent surgeries though, with the top surgeons, that it does come back. So they've said a 20% reoccurrence rate, or I don't know. I think there's different quotes from different surgeons, but the truth of the matter is it's an immune system disease. And so the state of your body that is happening after the surgery, before the surgery, this is why surgery alone is not the answer. You have to have a full approach with, diet, an anti-inflammatory lifestyle, getting those adhesions treated. A lot of the top surgeons say that they're recommending pelvic PT 48 hours, or not 40, 7 to 10 days basically. But in 48 hours, the scar tissue starts to form after the surgery. So not only do you have endometriosis lesions creating scar tissue, but the surgical procedure itself causes scar tissue. And your body has been dealing with the endometriosis for so long that there are repercussions in the nervous system and, everything else that's been left behind after the surgery that needs to be helped.
Oh, that's interesting. I'm kind of registering that there might be a cascade of things happening, because you're also removing something that your body's kind of gotten used to in some weird way.
Yeah. Yeah. There's a lot of protective mechanisms going on, like central sensitization, which is basically the nervous system takes over after a long time of having pain. The pain no longer is in the organ, it's in the brain.
Okay.
So it becomes this cyclical thing where the muscles are reacting to something very minor, but it's just been trained to be overreactive to signals. So we have to retrain the muscles of the nervous system and the organs and, just all that kind of thing.
Okay. So let's say I'm post-surgery, I'm post-embryo transfer, because I am, and it failed.
Okay.
And
Sorry.
No, that's okay. Thank you. I'm like back on the horse, ready to think about the next step.
Yeah.
And I'm thinking about calling you. What are we going to do in the 1 month lead up to the next embryo transfer, knowing what you know about the surgery, maybe reviewing how that went, and that I had another failure?
Yeah.
And I'm looking at you as like one of my team members because I'm acupuncture, my clinic. And then I'd love to consider this. So like, what would that look like as a patient?
Super effective acupuncture. Good thing you're doing that too, because those things go hand in hand. We would evaluate you from head to toe. We would do lots of internal work on your organs to make sure that there's nothing glued together.
Again?
There's like, the body just wants to glue those things back together.
Okay.
So we would work on the scar tissue, just helping the organs to like gently kind of manipulate the organs so that they're in a better position, help create blood flow to the uterus. Also work on the nervous system, like I mentioned before, just looking at, your cranial bones, making sure there's not a lot of asymmetry in there so that you're, all of the hormones and everything are flowing freely and, the signals are enhanced so that everything is more receptive to an embryo.
And is there anything that pelvic PT can help with in terms of recovery during IVF cycles? For example, post-egg retrieval, post-embryo transfer.
Absolutely. All the same things we would do.
Okay.
For sure. Just to like calm the nervous system down. It's a lot. And I know that sometimes with endometriosis, like you're giving all these hormones, right? You're like on the birth control, and sometimes that can exacerbate the endometriosis lesions if you have them. If there's still some endo lesions in there, or if you haven't had excision surgery, endometriosis makes its own estrogen. So, yeah, it does. So a lot of times when someone's going through the IVF cycles and they're getting all those hormones, that can like stir things up in the abdominal area. They can become more bloated, you get more symptomatic sometimes from those hormones. And, I know it's a step that you have to take to have a successful IVF, but it does sometimes make people more symptomatic. So we can help with like kind of getting the lymphatic flowing and getting the blood flowing and just kind of flushing things out and helping the body to feel better.
That might be related to the migraines then. I'm thinking estrogen rise and fall, right?
Absolutely. There's definitely hormonal migraines. And migraines are also another indicator of, if you have cyclical migraines, that's another sign that endometriosis could be at play.
So I've been to regular PT, if we call it that, like for a foot injury. Okay.
Yeah.
Pelvic PT, do you give people take-home exercises?
I do. Try not to overwhelm them with too many because what my practice is more manually based, meaning that we're hands-on. So you're with your therapist for the whole time. And we're like working on, just kind of following the tissues in the body and where the body's calling for work. So we do a little bit of intuitive, but also just like kind of manipulating things to make sure there's like symmetry and there's flow in the body. And then we give exercises to support that so that it lasts longer, basically. So whether it be mobility exercises or if someone's having a hard time connecting with their core, their pelvic floor. Typically with endo or IVF, it's more the other part of it. It's more the mobility, like keeping things mobile and open and all of that. Yeah, and as people, we give people more exercises after maybe like postpartum, after they've had their baby. So like we see people through the whole history of their, birth and
wonderful
infertility, pregnancy, all that stuff. Yeah.
Okay. Most people are told that if your fallopian tubes are blocked, then IVF is your only option. And I'm wondering, based on what I've read about you, is would pelvic PT, specifically the kind that you do, present other options?
Yes. I have been able to work on people's adhesions, and they've had clear HSGs after treatment. It's not a foolproof method. I can't claim that I can open your blocked fallopian tubes specifically, but it's worth a shot. So you can come and get treatment for blocked tubes, and we'd do all of the things. So it wouldn't just be working on that. We'd be working on freeing up all the organs from the adhesions. And then you can go and get another test to see if they're open or not. I think that's a really good first step if you don't want to go down the IVF route. I think that's like certainly worth checking out. And the benefit of that is more than just opening the tubes. It's like getting the whole pelvic area prepared for pregnancy, and also helps with pelvic pain and other things. So I've had patients that have come to me for that specific purpose, but they've said, even though you didn't open the tubes, my body has never felt so good, and I feel so much better. It was so well worth it. So, and then the people that, obviously that we did open the tubes, they're like, yay, and I got pregnant and all that stuff. So it's like, I just don't, it's like hard for me to make that claim, because it's probably like about a 60% chance that we could do it.
You're probably sharing that right now with people that have never heard that that's possible, though.
Right.
So that's
right.
huge.
Yeah, I had a patient. I love to tell this story. She came to me and she needed a note from her doctor to have her insurance try to pay for it. And the doctor was like, okay, I'll write the note, but I don't think it's going to work. And she was like,
no.
The best. It was the best when she like went back to him for the HSG and the tubes were open. She said his face was like,
wow.
He was eating his words. But of course he didn't apologize for saying, I don't think it's going to work.
That's the opinion, right? That's why you get 1, 2, maybe 3 opinions sometimes.
For sure.
I want to hear more stories now. Can you share any that were ending in a pregnancy for someone?
Yeah, for sure. Well, I had a patient that came to me from South Africa who was looking for help. She had 5 failed IVFs. And she came and had an intensive treatment with me, and she got pregnant. And then she had to have a C-section. So she had scar tissue from the C-section. And then she came back to me again and had another session of, another round of treatments. And she got pregnant again. Yay. So it was awesome. I mean, I've had a lot of our patients who have had excision surgery that went on to have IVF or even get pregnant naturally afterwards. I think most of them have conceived afterwards. So just having the treatment, I feel, is very beneficial.
Okay. So back to endometriosis specifically.
Yeah.
So it's very under-researched. It's very underdiagnosed. Yeah. Can take 10 years or so. What do you think needs to change?
Oh my gosh. So much. So much. I think the medical field, everyone needs to believe women. First and foremost, believe our pain, believe that we're struggling. We're not making it up. There needs to be way more research. The amount of research and the amount of money that goes toward men's health. If this was a man, somebody said in one of the documentaries, if this was a male problem, this would have been solved a long time ago. And it's really sad to think that this could be taken care of. I think there's a lot of research happening now. I think there's a lot more questions being asked, and I'm excited about that, but it's not happening fast enough. And I feel like, if I could just go walk around with my megaphone, like, hey, women, stop gaslighting us. It's just like really frustrating. Even within the medical field, we were just talking about the doctors that are saying they can do this surgery, or they're harming people. They're harming people by doing that. And I know they want to help, but I feel like the message is not clear that this is not a gynecological disease. It's a whole body disease that needs a whole body approach and needs specialists that treat it that way.
Say more about that gaslighting. That's powerful.
I mean, I have patients that come from their doctors and like, I've heard you're too young to have endometriosis. I've heard you can't have endometriosis because you've been on the birth control pills. Birth control pills don't stop the growth of endometriosis. Like, there's just so much. These are doctors are telling my patients
just like making connections for fun. Okay.
One doctor said, let's put you on a course of birth control pills, and if it works, then you have endo. If that takes away your pain, then you have endo. I'm like, that's not diagnostic. No, it doesn't work for people sometimes. Like, birth control is just a Band-Aid, really. I mean, it does help people with symptoms, but doesn't stop the disease from progressing.
I had a friend that her doctor told her, well, some people just have it, some people don't. There's really not much you can do with it.
My family doctor gave me Vicodin and like a whole bunch of medications, like narcotics and stuff, and said, I think you have endometriosis. And I was like, what is that? This was before the internet and everything. And he's like, you probably won't be able to get pregnant.
Wow.
I had to live with that for like many years, like worrying that I wasn't going to be able to get pregnant. No one told me what it was,
Yeah. Did anyone ever suggest a hysterectomy to you?
No, thank God. Wow. Thank God, no. But, I had to I sought out holistic people. I went to a nutritionist and she helped me with some herbs, and that helped me to conceive. But yeah, I was in debilitating pain for every period, like vomiting and just like an exorcism. Here's the gaslighting happens also at home. My mom was like, oh, I had those too. That's normal. Like, being told that that's a normal part of life.
Yeah.
That periods are supposed to hurt, that sex is supposed to hurt. And none of that's true.
Not at all.
That's all dysfunction. And that's all endo. And here's one thing I need to say is if someone has debilitating period pain and they're like go to the hospital or they can't participate in life, pretty much they have endo. They need to get seen. That is the key. There were times where doctors would just avoid it and they'd try to rule everything else out before ruling endo in. Why the heck are they not ruling endo in first? That is the first place they should be looking, not the last place. So there's the key. And I think that's part of what's going on in the medical field is that we're like, oh, let's not go there. There's no cure. We don't know what it is. Instead of like, okay, let's see, you probably have endo if you have that bad of pain every period.
Wow.
End of story.
Yeah, period.
Period. Yeah.
You've lived with endo yourself and your daughter is diagnosed, correct? So how does that change how you approach patients?
I think it just gives me a deeper insight into what they're going through. And even though everybody's different, everybody has a different experience with endo, I can commiserate more with where they've been. And I think it's interesting because I didn't have endo excision surgery as something on my radar when I was growing up. So I didn't even know that existed. So I went through my life off and on birth control pills because they were like, my body just didn't like them. So I would be, I'd try one for a while and then I would be off of it. And so up until having my daughter, the period pain was like a regular occurrence in my life. And I didn't get this kind of treatment. I didn't know pelvic, PT. I knew pelvic PT existed after PT school, but when I was in PT school, I was like, oh, hell no, I don't want to do that.
Oh, really?
Just because of my history, I was just like, it became a taboo like area for me. I'd be like, no, I don't want to, I didn't want to have natural birth. Like I didn't want to have a water birth or like have a midwife. I wanted to be in the hospital where I could have a epidural. I ended up having a C-section, but I was scared to death to give birth. And it wasn't until after I had my daughter and like went through certain things that I really learned more about endo and what was going on. And, it's just like, wow, if I had this information when I was that age, my life could be so different. you know?
Yeah.
And so I want that for my patients. I want them to know all of the things so that they can make the decisions to have a better life.
Oh my God. It just stands out to me being that afraid to have birth.
So afraid.
I mean,
yeah.
I think that's like compounded pain and fear over the whole women's health
totally
thing altogether, the whole experience.
Yeah.
And everyone screaming on TV when they're giving birth, it just makes it just sets you up for this.
Yeah.
Like, you know, everything is hell for our health. I've read some theories about where endo comes from. Why does this happen? What are you seeing now?
Yeah, it's a tricky subject. They still really don't know specifically where endo comes from. There's lots of ideas. And the old school way was that they thought it was retrograde menstruation. So basically menstruating through the fallopian tubes and into the abdominal and pelvic cavity. That's been disproven just because they've found it in areas where that would not be possible. So there is a belief that you're born with it. It's, you know, a cellular proliferation kind of thing that happens, you know, before you're born, actually. There are thoughts of different phenotypes. So they're exploring that because there's different presentations of endo from different people. So there's people that can have a low stage of endometriosis and have like severe symptoms. And then there are people that have a very high stage of endo that have barely any symptoms. And so that's very puzzling.
The high stage with no symptoms, is that what everyone's calling silent endo?
Yeah, but it's not really silent.
Okay. No, it's not. The research is silent.
The research is silent, yeah. And it's maybe not screaming at the body as far as pain goes, but dysfunction for sure. There's infertility. And, you know, some of my patients that have had the higher stages that had to go through IVF and like, as I probed more, they had definite digestive issues that they didn't really attribute to endometriosis. So, you know, the constipation or, oh yeah, I did have like bloating and, you know, abdominal stuff, or I did have this weird abdominal pain, but like it wasn't in the forefront because they weren't thinking that that was related. You know, the digestive tract and the pelvic organs are very closely together in the body. So there's definite, you know, back and forth from that. Yeah, so they think it's like cellular Müllerian cells that are, you know, in the embryo that kind of spread and sometimes they're triggered. Some people think they're definitely thinking it's a neuroimmune disorder. So they're looking at those kind of roots of the disease as well. So I think there's still a lot to uncover. It's immunological, it's inflammatory.
So we've come far on it, but kind of not fast enough.
There is a genetic component that I don't know that they've uncovered a gene, but you're 7 times more likely to have it if your mother or sister had it.
Okay.
So that's always a question I ask about the mothers and sisters or your aunt or whatever, you know, like.
I bet that's actually how the mother thinks about it for the first time in her life. If you're asking them to check with their mother,
right?
The symptoms probably say it, but I bet they didn't get diagnosed.
Yeah,
quite often.
And a lot of times those mothers had hysterectomies that they don't even know why they had them.
Yeah,
they're just like, oh, I don't know, I was having pain or bleeding or whatever.
Yeah,
like, they don't know.
Yeah,
I'm like, oh, that was endo.
Wow.
Yeah.
What would you say from your heart to someone going through IVF right now?
Find your people, for sure. Get yourself a group of people that are either going through, probably people that have gone through it or are going through it, or practitioners. Like find your practitioner group of advisors and go easy on yourself. One of the biggest things I need to let people know is that it's not your fault. And there's a lot of self-blame and shame within IVF and within endo. There's like just a lot of people are like, oh, it's that one thing I ate or that one thing that I did that like set me back. And really we have to stop shaming ourselves and going there. Like really try to find your joy, try to find things to distract you from it as well, because it can be like really overwhelming and all consuming I don't know if you've gone through that, but it's just, just constantly checking your charts and your, like all of that stuff can be really overwhelming. And so I'm always telling my patients that are going through that to please find some joy, find a little pocket of joy this weekend. What are you going to do? I always ask them, like, what are you going to do this weekend? You can do something fun? Let me hear. I got to hear what you're going to do. And if they're like, oh, I don't really know anything, I'm like, let's like create something fun. Let's do it. Like do something fun, like really create some joy in your heart, because that's what's going to make you feel better.
Well said.
Yeah.
Yeah. Because IVF can be extremely overwhelming. You're right.
Bad.
You're right about that.
Yeah.
And it doesn't have to stop the rest of your life.
Nope.
Well, Michele, thank you so much for coming on IVF Companion. This has been really enlightening for me, and I'm sure for many others who now have another resource to add to their arsenal for fertility.
Well, thanks for having me. I'm so happy that you're doing this for people that are going through IVF, because, like I said, they need their people, so you can be one of their people.
Thank you.
Yeah.
Hey, I hope you enjoyed this video. Please remember to like and subscribe if you want to be notified on what's happening next. Also, I would appreciate it very much. Look below for a link to a free packing list that I designed for anyone going to IVF in another country. Please, I promise that it'll be helpful, and I look for feedback on how have you tailored it to yourself. Another link is there to join the mailing list for IVF Companions, so I can keep you updated and hopefully send you an invite to our forthcoming community in Circle. Thank you.